Okay, good afternoon and welcome. I am honored to welcome you today to the second annual Dr. Alan L. Bisno Memorial Infectious Disease Lectureship. We are very grateful to Barbara Bisno and the Bisno family who are here today with us, and for the opportunity to remember and honor Alan's contributions over the more than 30 years that he spent here at the University of Miami Miller School of Medicine and the Miami VA. Dr. Bisno graduated with his bachelor's degree from Princeton University and then completed his medical degree at Washington University in St. Louis. He then completed internal medicine residency at Vanderbilt University and then spent 3 years in the public health service at the CDC. What would become his lifelong work on streptococcal bacteria began during his infectious disease fellowship in 1968 with Dr. Gene Stolman at the University of Tennessee Health Science Center. Serving as chief of infectious disease for most of his 19 years at the University of Tennessee, Dr. Bisno was regarded internationally as an expert in the diagnosis, treatment, and prevention of group A streptococcal infections. He made seminal observations regarding the epidemiology and pathogenesis of rheumatic fever and post-streptococcal glomerulonephritis, conducting a groundbreaking early clinical trial of a streptococcal vaccine, and brought attention to the importance of severe group G streptococcal infections. Dr. Bisno was a thought leader in the field of streptococcal disease, writing chapters for Cecil's, Harrison's, and Mandel's. He co-authored, and in many cases co-authored with Dr. Dennis Stevens, our speaker today, National Medical Practice Guidelines for the Diagnosis and Treatment of Streptococcal Diseases and Prevention of Endocarditis and Rheumatic Heart Diseases. Moving to Miami in 1987, Dr. Bisno was University of Miami Miller School of Medicine professor and vice chair of the Department of Medicine and served as the chief of the medical service at the Miami VA. It was during this time in Miami that many of us had the opportunity to get to know Dr. Bisno as a brilliant clinician and researcher who also had a very quirky sense of humor and a passion for teaching. He also notably had great dedication to his patients individually and collectively, with strong advocacy for the early diagnosis and treatment of necrotizing fasciitis in particular. He very effectively ensured that no ID fellow trained in Miami under him would miss a case of necrotizing fasciitis. It has been a pleasure to reflect on Dr. Bisno's personal and professional accomplishments with his family, and I would like to thank them again for continuing Dr. Alan Bisno's legacy of clinical, academic, and educational excellence with this Grand Round series. So thank you so much. Turn over the introduction to the chief resident. Here you go. Thank you.
Good afternoon. I am honored today to introduce our Grand Round speaker, Dr. Dennis Stevens. Dr. Stevens is a professor of medicine at the University of Washington. He completed a BA in microbiology at the University of Montana and a PhD in microbiology at Montana State University. He then went on and did medical school and in an internal medicine residency at the University of Utah, followed by a fellowship on infectious disease in the Brooke Army Medical Center in San Antonio, Texas. In addition to his duties, Dr. Stevens served as the chief of infectious disease at the Boys VA Medical Center in Idaho for over 30 years, as well as program director of the NIH Center of Biomedical Research Excellence in Re-Emerging Infectious Diseases. Dr. Stevens is the recipient of multiple accolades and awards, like the Honorable Society of America Lifetime Achievement Award and the VA Society of Practitioners in Infectious Disease Lifetime Achievement Award. He is an internationally renowned researcher with over 150 publications as well as book chapters. He has received impactful grants funded by NIH for his work on gram-positive bacteria, elucidating the life-threatening infectious clinical disease, characteristics and pathogenesis, as well as developing novel diagnosis, preventative and therapeutic modalities. These efforts have directly and significantly impacted medical practice to the benefit of the veterans he served, the medical student and junior investigators he trained, and the general population worldwide. It's with great pleasure that I introduce you Dr. Stevens.
Thank you. Thank you very much. Can you hear me all right? Well, it's Well, it's a great pleasure to be here and honor Dr. Alan Bisno. And we had several things we did together. We published an article in the New England Journal on streptococcal infections back in 1996. And you can see that Alan Bisno and I participated in the clinical infectious disease practice guidelines from the IDSA for the diagnosis and treatment of skin and soft tissue infections. And so Ellen and I were great collaborators, and I have the utmost respect for him. I'm going to cover several things. One is scarlet fever, which is illustrated here. A boy with measles on the left, your left, and scarlet fever on the right. And this is a picture of a German boy with scarlet fever. Notice the red cheeks, whiteness around the mouth, and you could see that he's got a diffuse rash on his thorax as well. Now, scarlet fever was really first described back in 1610 as Garotilo, and then it spread northward into Poland and England, where it was called morbus strangulatorius. So I think you get the idea that this was a nasty sore throat. And then Fothergill's sore throat, which is less descriptive, but that was by British people and not Italians. In our own country in 1736, there were 4,000 cases of scarlet fever, which was described as throat distemper, plague in the throat. And in 1737, there were 984 deaths. And then gradually, the scarlet fever epidemic spread further westward with the migration. Recent scarlet fever has really resurged, not only in England, in the United States, and several countries around the world. And just for a backdrop of sort of more modern things, 1920, 1930, there were 100,000 cases of scarlet fever per year in England. And then it pretty much disappeared. And you could see at the bottom line there in 2016, there were 19,000 cases in England. And even before that, in 2011 to 17, there were 400,000 cases of scarlet fever in China. And and it's kind of interesting that the epidemic actually was curtailed because of the isolation of people being sequestered because of COVID-19. So the epidemic sort of dropped off. And one of the important things about this epidemic in China is that 100% of the strains from scarlet fever of group A strep were resistant to erythromycin and clindamycin. And that's going to become very important as we go further. Well, George and Gladys Dick did some studies. Just a sec, I got to go back one. They did this test. They worked in Chicago at the McCormick Hospital in back in around 1910, 1920. And this picture shows a positive Dick test. And what they did was they injected culture supernatant from group A strep isolated from a patient with scarlet fever, and lo and behold, it caused a red skin rash. And now I got to go back one slide. And the next thing they did was to take serum from someone who had recovered from scarlet fever, and they injected that into the skin of someone that had scarlet fever. And you can see that it caused a whitening of the skin, which these two things show, number one, that you can develop immunity to scarlet fever, and number two, that a toxin produced by a group A strep is responsible for scarlet fever. Now, I just want to mention some surface components of group A strep that are important. And certainly the M protein, there's over 170 different M protein types of group A strep. And Alan Bisno and his colleagues at Memphis were hell-bent on developing a vaccine based upon fragments of the M protein from the N terminus. And we'll talk more about that later. But basically, they made a cocktail of roughly 20 different common strains of group A strep. They isolated the N-terminal amino acids and used that as an immunogen. And it seems to work, but it's only in phase 1 and phase 2 trials currently. And then the cell wall of the organism and the group carbohydrate, as you can see here, which is why they're called group A, because of the carbohydrate. And this is just an electron micrograph, I think, illustrating very beautifully the fuzzy coat of group A strep, and that's all M protein. Now, the other thing is group A strep is just absolutely loaded with toxins of various types. And I won't go into too much detail about them, but I just want to emphasize these up here, streptolysin O and the pyrogenic exotoxins, and we'll mention more about that. And then NADase, which could play a role in scarlet fever. But clearly the pyrogenic exotoxins act as superantigens and are potent inducers of cytokines. Now, we're going to go now through various skin and soft tissue infections. And I like this diagram because I think it points out that up here, the very surface, we can have vesicles and eschars, and we can have bullae. And obviously herpes and whatnot could cause these kinds of infections. But erysipelas is very superficial in terms of the kind of soft tissue that it infects. Cellulitis is deeper down in the subcutaneous tissue. And then necrotizing fasciitis occurs deeper, this being the fascia. And then you could have myositis or myonecrosis due to destruction of muscle by group A strep. And I personally think that necrotizing fasciitis is a misnomer. Most of the time that that diagnosis is made, there's destruction of all layers of the skin, all the way down to the muscle. So this all dies. And we'll talk about what the mechanisms of that are in a moment. So this is impetigo, very superficial. This happens to be group A strep, but impetigo, about 50% of cases now are caused by either methicillin sensitive or methicillin resistant staph. But you can have infection with both in a given individual as well. And obviously impetigo is described very well in the Indian reservations in South Dakota associated with post-streptococcal glomerulonephritis. And this is folliculitis. It's actually swimmer's itch, and it's not gram-positive infection. And then carbuncles and furuncles. And these are Staph aureus. This is a carbuncle. Furuncles are smaller, up to 2.5 centimeters across. But they are obviously virtually always Staph aureus. And I just put this slide in to show that you could be a nasal carrier of staph. And this is a good way to auto-inoculate yourself. You scratch your skin and lo and behold, you develop a carbuncle or a furuncle. So sometimes treating nasal carriage in people that have recurrent furunculosis is critically important. This was when MRSA was first being described. In the literature, it was called spider bite, but it's actually just a small abscess or a furuncle. But interestingly caused by methicillin-resistant staph. And then this is kind of a mixed bullous infection, impetigo, and soft tissue infection, also caused by methicillin-resistant staph. Now, this looks like cellulitis, and some people would call it cellulitis, but it isn't. A thoracic surgeon sitting in the audience would know that pus needs to be drained. And so that's what needs to happen. So this isn't cellulitis, it's erythema because of the localized infection, but this just basically needs to have a surgical drainage along with antibiotics. But I think it's a misnomer to call these things cellulitis. And I'm not going to mention much about surgical infections due to time constraints today, but I just wanted to put up clean surgery infection rate should be less than 0.5% in good hospitals. And those are almost always, when they do occur, almost always Staph aureus, occasionally Staph epidermidis. And then contaminated surgery, obviously we use prophylactic antibiotics for that, such as colonic surgery and so on. And then if there is a contaminated surgical site, such as a leakage of material at the surgery site from bowel contents, et cetera, then that's treatment. That's not prophylaxis. Now, this is scalded skin syndrome caused by Staph aureus, and it's caused by a toxin called exfoliatin produced by Staph aureus. So this patient, the picture over here basically presented what looked like cellulitis, but then the next day you see the skin sloughed. And you can demonstrate that with a positive Nikolsky sign just by sliding your thumb on the skin and the skin peels back. So that's a positive Nikolsky sign, and that's pathognomonic for scalded skin syndrome. Okay, I want to talk next about another kind of infection caused by Staph aureus. 25-year-old woman developed nausea, vomiting, chills, fever, diffuse sunburn type rash, had low blood pressure, tachycardia, and fever. And this is what her skin looked like. Almost looks like scarlet fever. But she used a Rely tampon and actually had staphylococcal toxic shock syndrome. This is a patient that had surgical drainage of an old shrapnel injury. The shrapnel injury was 20 years before, but it finally got drained, and then he got a secondary infection. And those are my fingerprints on his skin. So you could see that there's a definite blanching of the skin. And sometimes you can end up with a diffuse erythematous rash, like I showed you on the face of that woman. But sometimes it's interreginous areas, such as this male, and also in the axilla. So scarlet fever rash can be quite variable. And this basically shows a fair amount of swelling of the fingers due to diffuse capillary leak caused by the TSSD1 toxin from Staph aureus. And then a little bit later, you can see that the skin actually desquamates. So that's pretty classic skin and soft tissue infection. So I'm going to sort of close with the staph infections now. And we talk about purulent, and then over here we talk about non-purulent. And so the mild ones, as we talked about, furuncles, carbuncles, just incision and drainage, usually you don't need antibiotics. If it's a moderate severity where a patient has fever, or it's in a diabetic or a compromised patient, then you need to do IND, culture and sensitivity, and treat it appropriately. And obviously, it's hard to make recommendations about the exact antibiotic to use because it varies a lot from region to region in the United States. And then for severe infections like toxic shock syndrome, you need to use drugs like vancomycin, daptomycin, linezolid, and so on. And we'll talk a little bit more about those. Now, this is this is just a strain of Staph aureus that we studied. And you can see that this is a concentration of TSST1, the extracellular toxin causing toxic shock syndrome. And this is presence of antibiotics, no treatment, vancomycin, nafcillin, clindamycin, or linezolid. And you could see no treatment, that this is the amount of toxin produced in 8 hours. And with vancomycin and nafcillin, it's really basically unchanged. In contrast, protein synthesis inhibitors like linezolid and clindamycin totally suppress the toxin production. And so I'll try to convince you that choice of antibiotics should be dependent upon what you think the pathogenic mechanism is. And for toxic shock syndrome, it should be a protein synthesis inhibitor. So now we have a 40-year-old female who develops pain in the cheeks, fever, and chills. And this is what her face looks like. So she has erysipelas. So from the diagram that I showed you earlier, erysipelas occurs in the very outer layers of the skin. And it's usually bilateral. It spares the nasolabial fold, as you can see. And this is a man that had a tracheostomy. Again, you could see the really classic bright red skin in his nose and on both sides. So that's erysipelas. Cellulitis caused by strep. And as Alan Bisno pointed out, cellulitis can be caused by group C or group G strep, but it's more commonly group A. And so this is cellulitis due to group A strep. And the characteristics of it are that there certainly is red skin. It's a little bit more pink than bright red. And it's got a border, but it's much less distinct than we saw with some other kinds of infection. And this is just another more severe case of cellulitis caused by group A strep. And this is just a 30-year-old male who developed cellulitis below the knee and fever and chills, and then had this finding. And it basically shows lymphangitis. And lymphangitis is, in my opinion, most commonly caused by group A strep, and to much lesser extent, Staph aureus. But you want to treat the patient very aggressively, because by the time that gets up to the inguinal ligament, you're probably going to have bacteremia associated with it. Just a word about polymicrobial necrotizing fasciitis, just to be complete. And this could be so-called Fournier's gangrene. I'll show you a picture of that. And intra-abdominal disaster, post-hysterectomy, gunshot wounds to the abdomen, in all those things. So this is a diabetic foot infection, and you could isolate usually 4 or 5 different organisms, including Enterococcus, E. coli, or Klebsiella, and anaerobes. And obviously, this is a surgical emergency. This was a young boy that came to the VA at one afternoon because he had a little rectal pain and was examined. They thought he had a little hemorrhoid. He went home, awakened at 3 o'clock in the morning with excruciating pain, and came to the emergency room. And this was taken a couple hours after he came in, when he was in the operating room. And he's got Fournier's gangrene. And you could see gas in the tissue. There was palpable gas all the way up on his abdomen and down both legs and so on. And luckily, he got treated very aggressively with surgical debridement, 4 or 5 drains subcutaneously, and broad spectrum antibiotics, and he did fine. Well, I'm going to switch gears now and talk about invasive group A strep infections. This is a picture my daughter drew for me. The British coined the term flesh-eating virus, but I think we all know it's not a virus, it's a bacteria. And this is just the United States reports from the CDC, and it points out from around 200 and 210, a little over 10,000 cases. And then in blue is the mortality, which is over here. So about 10,000 cases and about 1,000. But then you could see that in the 2008, 2020 periods of time, there was a gradual increase in these cases of invasive infections. And this is also seen throughout the world. Now, there's 2 kinds of necrotizing fasciitis caused by group A strep. One is with the portal of entry, such as a cut, insect bite, surgical procedure, postpartum sepsis. And then there's no portal of entry. And this is the one that will really burn you. And this is the one that has the highest mortality rate. And I'm going to spend a fair amount of time discussing that with you. This is a lady that cut her finger on an airline on a piece of paper. She was a passenger, and she developed an ascending infection that went up her arm to her axilla. She developed renal failure, strep toxic shock syndrome, was in the hospital for 2 months. This is a man from Salmon, Idaho, that cut his hand on a corral pole and got a group A strep infection in it. And it ascended into his forearm and caused a necrotizing process there. This was a boy that had a little too much to drink on the 4th of July, riding his bicycle down a bike path in Boise, and he slipped off. And you could see he has a pretty severe thing. But notice the dramatic swelling of the affected leg compared to the other one. And so a diffuse capillary leak is very common with these kinds of infections. Now, the other one is postpartum sepsis, and we all know about Ignaz Semmelweis proving that physicians who didn't wash their hand were infecting women in Vienna, and Oliver Wendell Holmes in Boston about the same time, about 1850, described the same thing going on in Boston. Well, this is, we did a study of postpartum sepsis in modern times, and this is kind of the period of time before or after delivery. And it points out several things. One is some of these women actually developed infection before delivery, and that causes some real problems. And then those that developed infection within 0 to 2 days after delivery, many of them either were colonized with group A strep at the time of delivery, or they were infected in the hospital. And there was one OBGYN doc in Maryland that worked at 3 different hospitals, and he was responsible for 8 cases of group A strep postpartum sepsis. And in Northwestern Hospital in Chicago, there was an anesthesiologist that was in the room when 2 women at different times were delivered, and they both developed severe group A strep infections. And he was found to be a rectal carrier of group A strep in very good epidemiologic stuff. But unfortunately, the Chicago Times reported it as the anesthesiologist was passing gas and caused the problem. Okay, so now this is in my opinion, kind of the granddaddy, where strep is probably in the throat, could be asymptomatic, could be symptomatic. And then someone develops a trauma, a hematoma, for example, or a strained muscle. And so this is a 25-year-old male who strained his biceps while weightlifting. Pain improved after 24 hours, but then intensified by 36 hours, and he developed chills and fever. He went to the emergency department 48 hours after the muscle strain, had exquisite tenderness, no swelling, no redness, no induration, 10 out of 10 paid at the site of muscle strain, had fever, tachycardia, and lowish blood pressure. He was given morphine and Toradol and discharged on NSAIDS and Vicodin. Came back to the emergency room in 12 hours and had a creatinine of 4.5. White count was 11,000 with a big left shift, myelocytes, metamyocytes, toxic granulation, metabolic acidosis, and skin findings on this site. And this basically shows that he's got these hemorrhagic bulli, he's got skin sloughing, and you can see he's got pretty intense destruction of tissue all along here. And so when the muscle is explored, this picture basically shows this dark black muscle. And some people would call this necrotizing fasciitis, but it's not. He had full thickness destruction of the tissue. It's not just the fascia. So when you look at the Gram stain or histopathology of this, there's some striking things. One is you could see that there's some muscle destruction over here, and you can see that there are a ton of gram-positive cocci in the tissue all along here, and remarkably, zero white cell, zero influx of PMNs. And this is just another illustration of the same thing, but look at all those gram-positive cocci in chains in the muscle destruction. So, do NSAIDs adversely affect outcomes of infection? And I think they do, and this is a bad situation. You got a muscle strain, everybody takes ibuprofen, you got a muscle strain. And it makes it more difficult to recognize. It inhibits PMN function, suppresses IgG and IgM synthesis, and suppresses fever, relieves pain, and a reduction in rubor, calor, and edema. So that's a bad situation. Now, the complications of strep toxic shock syndrome are, as you'd guess, shock, ARDS, renal impairment, and it can be reversible if caught early, and bacteremia, amputation, fasciotomy are frequently needed, and mortality rate in our series was 30%. Other people have published that had actually even higher mortalities than that. Now, one of the things that we were interested in was the fact that we did echocardiograms on some of these patients, and you could see the mean age, portal of entry for the kind of infection that they had. And the first 24 hours, you could see the mean arterial pressure was low. They were tachycardic, and they were resuscitated in the emergency department with fluids. And this is what the dynamics of the echocardiographic findings were. And this is a cardiac index. And you can see it started out pretty high. That's what we expect with sepsis, high output cardiac failure, high output. And we're used with gram-negative sepsis of seeing that. And so guess what we do? We give vasopressors in that situation. But look what happened in this situation. The cardiac index went truly south. And so the outcomes were that there was a declining ejection fraction in the 15 patients, global or diffuse hypokinesia, segmental akinesia, and then of those that survived, they had follow-up echoes at 180 to 600 days, and it showed complete resolution of the cardiac abnormality. So 14 of 14 received at least one pressor agent after saline, and 21% had improved mean arterial pressure and cardiac index, and 78.5% had decreased cardiac index when they were given vasopressors. So the mortality was 55%, and 3 patients got balloon assist devices. 1 survived. 6 of 9 survivors had symmetrical gangrene requiring forelimb amputation. All had received vasopressors. So I only make a big deal out of this because this isn't like the usual kind of sepsis that we're used to treating with pushing fluids like crazy and giving vasopressors. If there's any question, you should do echocardiography on these folks. So the other big clue is to strep toxic shock syndrome is the hematologic. And I can't emphasize this enough, of a tremendous left shift of myelocytes, metamyelocytes. The mean white count is only like 11,000. It's not a big left. It's not a big white count, but there's a lot of immature cells, decreased hematocrit, thrombocytopenia. Creatinine elevations frequently go up before the patient develops hypotension. And that's a good clue. And that's because creatinine is being liberated by toxins from the group A strep. And hypocalcemia, CPK elevation is another huge clue. If there's any question about whether you're dealing with some deeper seated infection that you think, it's not unusual to have CPKs of 10 or 15,000 in that situation. So how does all this happen? Well, this is just a diagram of an antigen presenting cell, macrophage, and a T cell. And these super antigens called pyrogenic exotoxins have the ability to bind to both the MHC class II and the T cell. And so they stimulate both. So the macrophage makes TNF, IL-1, and IL-6, and the T cell produces interferon gamma, TNF beta, and IL-2. So it's a tremendous cytokine storm associated with these kinds of infections. And we did some studies in baboons to see whether or not we could have an impact on treating with an anti-TNF monoclonal antibody. And so we had a low inoculum. You could see that animals developed a drop in blood pressure, and then it gradually came back up on its own, not to normal. But then the high inoculum, blood pressure came down and it stayed down. But if we gave them anti-TNF monoclonal antibody, you could see the blood pressure stayed up. So I don't think there's too much question, but that could potentially be a good response. And this is just showing the mortality in the high inoculum and the anti-TNF monoclonal antibody. Okay, I want to share with you some animal studies we do. And as you can see, we take privacy issues very important. And we developed an animal model of severe group A strep infections. And this is the survival at 14 days. And this is the animals that were not treated with anything. And so survival was only 20%. But you can see with penicillin in the green, if we started treatment immediately, we could save 60%. But if we waited even 2 hours, mortality went down. It really wasn't any different than untreated controls. But up here, once again, clindamycin, we could delay treatment for several hours and still realize a pretty substantial improvement in survival. And so why does penicillin fail? Well, it obviously doesn't do anything to toxin production. And the penicillin is most effective if organisms are in the log phase of growth. Whoops. Huh. Go ahead. Go ahead. Okay. So what we did here is we took penicillin, measured penicillin binding proteins. So we took the organism and ground it up and did electrophoresis, and we used radio-labeled penicillin. And you could see that during the log phase, there were essentially 5 different penicillin binding proteins. But over here in stationary phase, you could see the penicillin binding proteins were not expressed. And so penicillin likes rapidly proliferating organisms, but it doesn't do well if they aren't. And this is just a strain of group A strep growing happily. This is a strain of group A strep in the presence of penicillin. And you could see these organisms are intact. This one's a little bulged, but they continue to produce toxins. So the mechanism of action of the clindamycin is obviously it shuts off protein synthesis, and that's why those drugs are more effective. I think I only want to say that these studies on IVIG in humans are really kind of complicated. And, you know, these necrotizing fasciitis infections are kind of rare. So it takes quite a center to be able to get enough good cases together over a short period of time. So I'm not criticizing the people who did these studies, but there 2 studies showed that there was no improvement in survival with IVIG, and other studies have shown the mortality was reduced in the IVIG arm if given with clindamycin. And one of the problems with IVIG is it's not really standardized. It's all different batches from all different parts of the United States and the world, et cetera. But I'd do it. I'd use it. I think you need all the help you can get. And but for sure with that. And then this basically shows that here's our friend clindamycin in the green, and this is the percent of control tumor necrosis factor, 100%, as you could see. And with penicillin, there really isn't any change in the quantity of TNF being produced, but with the cyclohexamide, which is a protein system inhibitor, and clindamycin, there is a reduction in tumor necrosis factor. So it's probably an added benefit. Now, this was, I was given a lecture in Geneva, Switzerland, and they presented this case to me of a 14-year-old girl that developed group A strep empyema. And this is her father 2 days later that developed this lesion, which kind of looks necrotic, and it was, and he developed group A strep necrotizing infection of his chest wall. So secondary prophylaxis, I think, is something you really need to consider. Again, there's not wonderful studies, but I think just use your brain, and you probably should treat family members or hospital workers who have contact with the case of invasive infections. And it really depends upon the closeness of the contact and the duration of treatment. But you'll find guidelines that say everybody ought to get treated with penicillin prophylactically. And then there's others that say, you know, be a little bit more selective. Okay, I'm going to spend just a couple of minutes on gas gangrene. This is Clostridium perfringens infection. Again, it looks ugly. Lots of swelling, redness, purple, violaceous bullae. And if you look at the tissue, again with gas gangrene, here's the muscle. Here's the muscle, and here's the gram-positive rods producing. And once again, gang, no white cell, no inflammatory reaction. It's not me. Oh, it is. Yeah. Okay. Well, anyway, I think you're all aware that there's been lots of earthquakes in various places around the country. And a big risk factor for gas gangrene is this kind of trauma. And here in Oklahoma, China, this was very interesting to me. 20% of patients with open wounds develop gas gangrene. And the reason was the average time to reach a medical center was 3.5 days. So you got an open wound that's contaminated with dirt, and bad things are going to happen. And so these kind of traumas are really important. And this is just another case of gas gangrene of a 13-year-old boy fell from a tree, had a penetrating injury to his buttocks from a twig, came in, emergency department, wound is explored, irrigated, sutured, closed. Probably not a good idea. Treated with amoxicillin. And then, as you can see, 16 hours later, had maroon drainage, hypotension, tachycardia, renal failure, gas in the tissue. They found a 3-inch piece of wood recovered on exploration, and they saved his life, but they had to disarticulate his hip. And once again, same thing we're talking about. This is percent survival in an animal model. And this is control. You can see that all these animals died very quickly when injected with Clostridium perfringens intramuscularly. And this is Pan-G in the blue, and you could see it helped a little bit, but not much. But then you could see that clindamycin and tetracycline, both of which are protein synthesis inhibitors, work very well. So again, there's Clostridium perfringens, and there it's growing. It's a phase contrast micrograph, and there it is in the presence of penicillin. It's lost some of its cell wall, but it's still viable. It forms these long filamentous forms, but continues to produce toxin. And then these 3 different bugs can certainly be associated with perfringens novii and sordellii infection, and that's skin poppy black tar heroin, and those could be really ugly. Okay, so this is another case of gas gangrene and no portal of entry, no trauma, etc. You can see he's got gas in the tissue. And but the interesting thing was that he had adenocarcinoma of the colon, and that was the source of the organism. And then just to close, this is a really nasty one of Clostridium sordellii infections. Yeah. Well, anyway, the clue about Clostridium sordellii is that the white count is incredible. It's not unusual to have a white count of 150, 200,000 with a left shift. And so that's a huge clue. In the world's literature, no one has ever survived a Clostridium sordellii infection, unless it's skin popping black tar heroin, in which case you got a clue. But it's a leading cause of postpartum sepsis in women, and certainly can also be associated with traumatic injuries. Okay, thank you.
Thank you, Dr. Stevens. That was a beautiful textbook review of many of the infections that some of our house staff, I'm sure, have never seen, but now will be aware of. And I guess we should have had a warning about lunch being served during the course of these beautiful pictures. We have a few minutes for some questions. Maybe I can begin by, you showed us in the latter part the high incidence of gas gangrene during natural disasters, and unfortunately, we see these more and more frequently, given the what's happened in Turkey and Syria in just the last month or several weeks. So if you were, and we often do send medical personnel overseas to these affected areas, what would you say would be the main thing they should, from an infectious disease perspective, bring in their toolkit that should be given and given widely during these episodes?
Well, number one, if they have contaminated wounds, that has to be taken care of. That needs to be debrided. If there's any devitalized tissue, that has to be removed. And then you'd need to decide whether you wanted to use a penicillin or clindamycin or something to actually treat it. But the one in China, 3.5 days before they actually got to see a doctor and had open wounds, I think that's difficult.
Yeah.
So the takeaway would be that try to get in there as quick as you have. I think you're going to have some good vascular surgeons and whatnot to debride and do reanastomoses and all of that. And that's tough in that kind of environment. 46,000 deaths in Turkey and Syria. You can imagine what the healthcare system is like.
Our good friend, Dr. Sackstein, on the other side of town, I see is on the Zoom, and he has a question. Bob, you want to unmute yourself and ask your question?
Thanks so much, Dr. Weiss, and I want to thank Dr. Stevens for this very comprehensive review today. I think Dr. Bisno is smiling down on all of us. I thank you for that, sir. I have a question about the left shift associated with the Penniclostridium infection. In my days when I used to do hematology consult, about once a year, I would get a consultation for rule out chronic myelogenous leukemia for a patient that had a C. difficile infection. And I'm just wondering if that sort of thing is the same pathophysiology we're seeing with this Penniclostridium. As it turns out, C. difficile induces high expression of GCSF, granulocyte colony stimulating factor. Is that what's etiologic with this type of infection as well?
Yeah, GCSF can be produced by some of these organisms, but it's also a release phenomena from the bone marrow, where the endothelial cells lining the bone marrow actually release preformed immature cells quickly. And C. diff, you're right, there can be a leukocytosis with it, but that's usually pretty mild. You might end up with 15,000 or 20,000, but not 100, 150,000.
Thank you very much. I'd like to thank the Bisno family once again for providing the resources to have these important lectures so that our faculty and house staff can continue to learn about all different areas, including infectious diseases. I want to thank all of you for attending in person as well as online, and to please check the chat on the QR code on your way out in order to obtain CME and MOC credit. We'll see you all next week, and thank you very much.